Starting with the lecture on conjunctiva, guys. The most loved topic by all of the students. Loved because we have studied it. Yes. Loved because it is easy. Loved because whatever questions are asked from it, usually you will get them correct. Let's start with this basic image and the parts of conjunctiva in this. So what is conjunctiva first of all? As already mentioned, conjunctiva is a transparent or translucent mucous membrane. Yes. This is covering the eye. But which part of the eye? The first thing that you want to remember is there is no conjunctiva over the cornea. Over the cornea, we don't have any conjunctiva. Okay? Now, apart from this, where is the conjunctiva? The conjunctiva is this, everybody. The conjunctiva is this. That means it is covering which part, everybody? Sclera. Yes? So the part of conjunctiva which covers the sclera gets the name bulbar conjunctiva. Am I clear? Then, if I show the posterior part of my eyelid like this, the lower eyelid, or if I evert my upper eyelid, everybody, what you will be able to see inside the posterior layer of the eyelid is palpebral conjunctiva. So I am saying lines the eyelids, inner surface of eyelids. Yes, everybody, I hope we understand this. Now, between the bulbar and the palpebral, there is a shallow depression present. That is known as forniceal conjunctiva. So you can see everything labeled in this diagram. Please remember these terminologies: bulbar, forniceal and palpebral. Am I absolutely clear about this? No confusion here? Now, apart from these three parts of the conjunctiva, you should also know this, everybody. There are two specialized folds of conjunctiva. Okay? In the figure, you will see them marked 10 and 11. 11 is known as caruncle. And 10 is known as plica semilunaris. Both these are rudimentary structures, everybody. Yes, caruncle contains importantly hair follicles. So in a lot of patients in old age specifically, you will see small hair coming out from this point, the medial point. This is the medial edge, everybody. I hope you understand this, that this is the medial edge. Okay, everybody. Then plica semilunaris represents the nictitating membrane in animals. In humans, it has no use. It is a rudimentary structure. So just know this. This is a small fold which is visible on the medial side. So this fold, everybody, this is plica semilunaris, and this elevation ball-like structure, this is your caruncle. Just be aware of these two names. Now, after we know these basic parts or terminologies of the parts of conjunctiva, let us do the histology of conjunctiva. Histology means layers. So number one, the outermost layer of conjunctiva, just like everywhere else, will be known as epithelium. Now, the epithelium of conjunctiva is actually continuous with the epithelium of cornea. Yes? So it is the same as the corneal epithelium. What was the epithelium of the cornea, if you remember? Non-keratinized, stratified and squamous. Okay, so very easy to remember. Just like the corneal epithelium, it is continuous basically. Importantly, the epithelium contains a specific type of cell which is known as goblet cells. Very important, guys, goblet cells. Goblet cells secrete mucin on parasympathetic stimulation. Okay, everybody? They secrete mucin. That's the important word here. Goblet cells secrete mucin. Why is mucin an important thing? Why am I emphasizing on this? Because mucin forms the innermost layer of tear film. It forms the innermost layer of tear film. Am I crystal clear? So conjunctiva is helping the tear film, everybody. Formation of tear film. Just remember this much. We will use this again when we are studying the tear film, the dry eye and everything else. Secondly, everybody, this epithelium also consists of melanocytes and Langerhans cells. Okay, no confusion. Now, This is the outermost layer. Number 1 we have written epithelium. Important concept of goblet cells. Number 2 layer, everybody. This is called the adenoid layer, or I can call it the lymphatic layer, adenoid tissue or lymphatic tissue. The important point about this layer is that it develops after 3 months of age. Please remember this. So there cannot be any lymphoid reaction of the conjunctiva before 3 months of age. Done? And then the last layer is the fibrous layer. This fibrous layer consists of the nerve fibers and the blood vessels and everything else. Am I absolutely clear? No confusion about this. Simple histology, the main point being the goblet cell point, everybody. Done? Simple question was asked, I think in DNB 2015, goblet cells are present where? Corneal epithelium, corneal stroma, conjunctival epithelium, conjunctival stroma. So we have to remember the location of the important cells, that is goblet cells. Now, after we have done the histology, let's see the lymphatic drainage of the conjunctiva. Why are we discussing the lymphatic drainage of the conjunctiva? If you will take note, we have nowhere discussed the lymphatic drainage in any other structure of the eye, neither in the cornea, lens, uvea, anywhere. We are discussing the lymphatic drainage here because the first important question, lymphatic drainage from eye occurs only in conjunctiva. So conjunctiva is the only structure of the eye, everybody, which has a lymphatic drainage. Please remember this. That's why this is a simple question. Lymphatic drainage in the eye occurs from. Am I crystal clear? Now, if lymph is draining, it must be draining into some lymph nodes. So where does the lymph drain? So lymphatic drainage occurs in 2 places, medially and laterally in different lymph nodes. To understand this, let's look at this figure and let's understand very simply how to learn this. I simply say lymph flows like your tears flow, right? जैसे आंसू बहते हैं वैसे lymph बहता है. So if you are crying right now, let's say you are sitting on a table, if you are standing and you are crying, your tears will start from which point of the eye? Medial. They will go over your cheek, everybody, and then they will go here. They will hang from here and then do tup, tup, tup. Yes. So lymph also, as you can see in the figure, from the medial part flows over the cheek and goes here and goes here. That means it is going below the mandible. Below the mandible, which lymph nodes are present, everybody? I hope all of us know. Submandibular lymph nodes. So medially, they flow into submandibular lymph nodes. Okay, everybody? What about laterally? Again, think about crying, everybody. If you are lying down on your bed after a hard day's work, let's say your day has not gone very good, everybody, जिसको हम कहते हैं सिसक सिसक के रोना, right? You're lying on your bed and you are crying like this. Now all your tears will start from the lateral point. They will go like this, like this, like this, like this, and then they will collect in your ear, everybody. Auricle. Before the auricle, preauricular. And they will also go down here, everybody. Parotid, superficial parotid. So preauricular and superficial parotid lymph nodes. Am I clear, everybody? So if you forget this, just think about crying or just cry. You will be able to see medially going into the submandibular, laterally going into the preauricular and superficial parotid. So this is one question which you should not get wrong. If you don't know any of the other questions, I hope that doesn't occur. But if you don't, you would already be crying in a paper. At least get one question right. All I'm trying to say is it is very easy. Please don't forget this. Am I crystal clear about this? Done? So this is your basics of conjunctiva. Basic simple questions, right? Now, let's begin with the main disease in conjunctiva. The main pathology, that is conjunctivitis. Inflammation of conjunctiva. If you don't know conjunctivitis, then think about eye flu. All of us have had eye flu a lot of times, everybody. Season changes, you have eye flu, bacterial eye flu, right? We say flu ho gaya aankh mein. So eye flu is a very common occurrence, everybody. This eye flu is called as conjunctivitis, inflammation of conjunctiva. Now, what will be the symptoms when you have eye flu or conjunctivitis? Think about it. What are the complaints you do? Number 1, your eye becomes red, redness. Then you have some kind of a discharge, which leads to stickiness. The patient will usually complain when they wake up in the morning, their eyes are stuck, everybody, eyelids. They can't open their eyes. Then they may have foreign body sensation, some grittiness. Then they may also have associated lacrimation and itching. Itching is specifically there if it is an allergic case of conjunctivitis. Obviously, itching denotes allergy, everybody, yes? Plus, please remember, if the patient is complaining of severe pain or if the patient is complaining of loss of vision, then they are actually not symptoms of conjunctivitis. That means along with the conjunctiva, due to the pathology, cornea has also been involved. So there is keratitis along with conjunctivitis. So pain and loss of vision should denote a more severe disease of the cornea, not only of the conjunctiva. This you need to remember clinically when you are sitting in your OPDs. Am I absolutely correct? Yes? Now, when the doctor will see it, what will be the signs? Let's see the signs, everybody. So these are the signs. Number one. Again and again, as I say, the redness to a patient is congestion or hyperemia of the blood vessels to the doctor. Yes, this congestion or hyperemia can present in two ways. The first one, everybody, this is called as conjunctival congestion. And the second one is called as circumcorneal. Once you know the names, let's try to understand the difference. In conjunctival congestion, if you will see, around the limbus, there is very less congestion. The congestion is mainly peripherally. Whereas when I say circumcorneal means around the cornea or around the limbus. So the main congestion is around the limbus. Am I absolutely clear? Conjunctival congestion, as the name suggests, is what you see in conjunctivitis. But circumcorneal is what you see in other disorders causing redness, like glaucoma, like uveitis, like corneal ulcer. So if you are observant enough, just by looking at the type of congestion, you will be able to note down. So red eye differential diagnosis. Just by noting the type of congestion, you may be able to diagnose the case. Am I clear to everybody? No confusion? Now, let's move on to the second sign, everybody. The second sign is simply subconjunctival hemorrhage. Due to inflammation, some of the conjunctival vessels may break, they may hemorrhage. So there will be a circumscribed area of hemorrhage. This has no treatment on its own. It will resolve within 2 weeks on itself. Am I clear to everybody? Subconjunctival hemorrhage. Then third sign, everybody. Third sign, you may not have heard of this word, chemosis. So what is chemosis? We are writing first of all, swelling of bulbar conjunctiva. Swelling of, I am not saying conjunctiva, I am specifically saying the word bulbar. Yes, only the conjunctiva which is covering the sclera that becomes swollen. As you can carefully or clearly see in the image, it looks as if somebody has filled up a polythene with water and that is almost swollen, bulbar conjunctiva. So this is a classic case of chemosis, usually seen in severe conjunctivitis. Then everybody, there will be discharge from the eye, obviously, because there is stickiness. Stickiness is due to discharge, everybody. This discharge is usually either mucopurulent or it is watery. Okay, this discharge will lead to, as you may see written, stickiness and also colored halos. If you remember the differential diagnosis of colored halos, which has been discussed in detail in the chapter on glaucoma, you would know there are 3 causes of colored halos. Number 1, mucopurulent conjunctivitis. Number 2, cataract. Number 3, glaucoma. Yes, in conjunctivitis, the colored halos occur due to the discharge which collects over the ocular surface. So when you wash the eye, everybody, the halos will disappear. Wash eye, halos disappear. Am I clear? We've written it there also. I've mentioned it here also. Done? Then the next sign is the important sign, inflammatory reactions. When conjunctiva is getting inflamed, what will be the sign in the conjunctiva itself, the conjunctival tissue that you will be able to see? So we say there are 2 types of inflammatory main reactions. The first reaction is called as a papilla and the second is called as follicles. Papilla and follicles. So what is a papilla and what is a follicle? That is the main thing that we want to know. Follicles are lymphoid aggregates. Okay? Follicles are lymphoid aggregates. So if we correlate it with the anatomy, the lymphatic layer is formed after 3 months of age. So for the first 3 months, you will never be able to see any follicles. Am I clear to everybody? Then what are papilla? Papilla are basically hypertrophied vessels. So that's a vascular abnormality. Now, based on this simple explanation of what a papilla and follicle is, can you understand, can you visualize what kind of an image you will see? If it is a hypertrophied vessel, everybody, papilla, that means you will be able to see elevations of what color, everybody? Vessels, red color. Yes? So let's see the photographs. Let's see the photograph, everybody. What is this? This is a papilla. You are able to see a lot of elevations, small elevations, but all those are red in color. Am I clear? Now if I see follicles, everybody, follicles are lymphoid aggregates. Lymph is not red in color, it is white in color. So whatever deposits, whatever elevation, whatever reaction will you see will be white in color. So if I mark it out, you see a white area, a white kind of a small nodule, everybody, flat topped, slightly raised, everybody. Yes, all these are follicles. Am I clear, everybody here? Yes. So you are able to see all these follicles in this. Yes. So when you are seeing a patient of conjunctivitis, this is the main thing that you want to do as a consultant, as a doctor here, everybody, that you want to be able to differentiate between a papilla and a follicle. Because a papillary conjunctivitis is absolutely different causes than follicular conjunctivitis. That is what you want to know. If you know this table that I am going to draw here, you will be able to diagnose each and every case of conjunctivitis. Either there can be a papillary reaction, or there can be, as we just now saw, a follicular reaction. And this will always be associated with a discharge. And as we mentioned, there can be two types of discharge. Either a mucopurulent discharge or a watery discharge. So everybody, I see a papillary reaction along with a mucopurulent discharge. If I see this, then I always have a bacterial conjunctivitis. If I see a papillary reaction with a watery discharge, then I have an allergic conjunctivitis. Similarly, if I see a follicular reaction with a mucopurulent discharge, I have chlamydial conjunctivitis, chlamydia trachomatis. And lastly, everybody, if I have a follicular reaction with a watery discharge, I have viral conjunctivitis. So this simple 2x2 table, everybody, if we remember this table, we will be able to group, we will be able to diagnose which type of conjunctivitis it is. Am I clear? Absolutely, everybody. So please make sure that you remember this, that you know this, right? This also tells us that there are 4 types of conjunctivitis, everybody: bacterial, chlamydial, allergic, and viral. So we have 4 groups that we want to study. We will start first of all with bacterial conjunctivitis. So let's start with the first type of conjunctivitis, the first group, everybody, bacterial conjunctivitis. As we've already seen previously, that bacterial means there will be papilla with mucopurulent discharge. That is what we have written here again, papilla plus mucopurulent discharge. Please remember that will be true in every case of bacterial conjunctivitis. Am I clear? We will be reading some types of bacterial conjunctivitis, to be specific 5 types. The first type I am writing, which is simply known as acute mucopurulent conjunctivitis. No specific feature, guys. The only specific thing is you need to know the most common bacteria associated, and that is our favorite bacteria, Staphylococcus aureus. And the treatment is simply topical antibiotics. Okay, everybody clear about this? Done? Now, second type of conjunctivitis, bacterial, is a very important name which I am writing, a specific condition which is known as acute purulent conjunctivitis, or known as hyperacute conjunctivitis, or known by another specific name which is Blinoria. Okay? So acute purulent, hyperacute, Blinoria. As you would be able to see in the name, there is no mucopurulent discharge. There is only pus which is being secreted, purulent discharge. Okay? The cause here most commonly is Neisseria gonorrhoeae. Okay, everybody? Because it is Neisseria gonorrhoeae, it is said to have an oculogenital transmission. Gonorrhea will affect the genital parts. So from genital parts to the eye, everybody. Okay, everybody, that is the transmission. Now, what are the specific clinical features? Look at this photograph, everybody. As soon as you see this photograph, you are able to see the specific clinical features. Number one, there is copious discharge. So much of discharge that the patient is not even able to open the eyes. There is swelling of eyelids. The palpebral conjunctiva is so affected that the eyelids are swollen. Okay? They are almost, we say, overhanging. Thirdly, the patient has intense pain. And lastly, everybody, it is associated with preauricular lymphadenopathy. These are the 4 specific clinical features of a case of acute purulent conjunctivitis. Everything can be remembered just by this photograph. That there is copious discharge, there is absolute swelling of the eyelids, there is intense pain and preauricular lymphadenopathy. Am I crystal clear about this? Done? Now, what is the treatment of this condition? Obviously, the treatment has to be based on Neisseria now. So for Neisseria, we have to give IM ceftriaxone 1 gram single dose, followed by oral erythromycin for 2 weeks. Okay, everybody? Done? Simple. Then the third type of bacterial conjunctivitis is named as acute membranous conjunctivitis. From the name, it is clear that some kind of a membrane is forming. Okay? But before we see the membrane, let's see the cause, everybody. So, the cause in non-immunized children. So, kind of a historical question. Immunization these days is very good, covers almost all the children, everybody since birth. Is Corynebacterium diphtheriae. Okay, everybody? But the most common cause, you can say, in adults for this membranous conjunctivitis is pneumococcus. Okay? So please do remember these 2 different questions. Answer diphtheria only if non-immunized children is mentioned in the question. Otherwise, you can say the most common cause overall is pneumococcus. Now, what is forming here, everybody? As is clear from the name, a membrane. So this membrane is fused with underlying conjunctival epithelium. That is why it bleeds on removal. That is basically how we are diagnosing it. If you try to remove the membrane because it is already fused with the underlying anatomical structures of the conjunctiva, when you try to remove it, the blood vessels will rupture and there will be profuse bleeding. Why is this important? This is important to know because of the next condition. The next condition I am writing is acute pseudomembranous. You understand the name difference, everybody? This is not a true membrane. Acute pseudomembranous conjunctivitis. Okay, everybody? Now, this is called a pseudomembrane because it does not fuse and thus does not bleed on removal. So whenever you see a membrane, it can either be a true membrane like in membranous conjunctivitis or it can be a pseudomembrane. How to differentiate? Try to remove it. A pseudomembrane is almost like a tape for everybody. When you will remove it, it will get peeled off very easily. There will be no bleeding. But had it been a membrane, there would have been profuse bleeding. So you will be able to see the same thing in the image, everybody, that we have taken a forceps and we are peeling the membrane out. It is easily coming out. This is basically organization of exudates, nothing else. Am I absolutely crystal clear about this? Done? Now, let's move on to the last condition, everybody, in bacterial conjunctivitis. Again, a specific condition which is known as angular conjunctivitis. Also known as diplobacillary conjunctivitis. Angular conjunctivitis, also known as diplobacillary. It has a specific cause, everybody. What is the specific cause? Moraxella lacunata or Moraxella Axenfeld. Moraxella are called as diplobacilli. That is why this conjunctivitis gets the name diplobacillary conjunctivitis. I hope you understand this. There should be no confusion about this. Am I absolutely crystal clear in this, everybody? Now, what are the specific clinical features, everybody? Let's look at this photograph to understand the specific clinical features. This is called as angular because this is affecting specifically this part of the eye where both the eyelids meet each other, canthi. Or I can say both the eyelids are meeting each other and thus forming an angle, everybody. Yes? I'm not talking about the angle of anterior chamber. Please don't confuse yourself. Yes? We're talking about the eyelids here. So this point, angle kind of a form, that's why known as angular. Okay? So what is there, everybody? As you can see, there is excoriation of skin at medial canthi. Excoriation of skin at medial canthi. That's the main thing. Proteolytic enzymes are released by the diplobacilli and that lead to maceration and excoriation. Secondly, everybody, there is reddening of intermarginal strip. Basically, guys, if this is my eyelid, anterior surface, posterior surface, so this is my margin, everybody. Yes or no? From where my eyelashes come out. This is where my eyelashes come out from. Am I clear? So this is red, everybody. Intermarginal strip. I hope you understand, even though I've drawn a quick diagram. This will be my eye, everybody. Cornea, sclera. This will be my upper eyelid. This will be my lower eyelid. So intermarginal strip, reddening is seen. Done? Thirdly, everybody, this is frequently associated with blepharitis, inflammation of eyelid margin. Am I clear? These are the classic symptoms. The patient will say, yahan par problem ho rahi hai. So the patient will be itching this, rubbing this. You may even see a kind of a small wound or a cut formed here. Okay? Now, what is the treatment, everybody? The treatment is, number 1, tetracycline 1% eye ointment for at least 2 weeks. It takes slightly longer, but at least 2 weeks. Secondly, this should be accompanied by zinc boric eye drops. Zinc prevents the proteolytic activity. Yes or no? Zinc boric eye drops. So this is the classic treatment that you need to give. If you give any moxifloxacin or anything like that, the patient's symptoms will not be relieved. So you have to be able to diagnose this specific condition, specific bacteria, specific signs, specific treatment. Am I crystal clear about this? So that's it about my 5 types of bacterial conjunctivitis. Very easy. I hope you can remember them. Nothing difficult, just some specific conditions here. Very easy to answer, right? We move on to the second group of conjunctivitis, that is viral conjunctivitis. Now, lots of viruses can cause conjunctivitis. The most common viral agent, everybody, implicated in the causation of conjunctivitis is adenovirus. Adenovirus can cause various manifestations. The first is called as non-specific follicular conjunctivitis. It is non-specific because it does not present with any specific clinical feature. The only thing present is follicles. Okay, everybody? As we know that follicles plus watery discharge will be seen in all cases of viral conjunctivitis. Now, this is usually caused by types 1 to 11 and 19. Okay? The second manifestation, everybody, is called as EKC, epidemic keratoconjunctivitis. Epidemic keratoconjunctivitis, EKC. This is caused by serovars or types 8, 19, 37. 8 plus 19 is equal to 27. Instead of 27, it is just 37. Thirdly, PCF, the third clinical manifestation, known as pharyngoconjunctival fever. This is caused by types 3, 4, 7. 3 plus 4 is equal to 7. I hope there is no difficulty in remembering this. Please remember, PCF, pharyngoconjunctival fever, specifically presents with, apart from conjunctivitis, with preauricular lymphadenopathy. So you can say it is almost the diagnostic sign of a case of adenoviral pharyngoconjunctival fever. Conjunctivitis, pharyngitis, and obviously along with that, preauricular lymphadenopathy. That's all about adenoviral conjunctivitis and its 3 manifestations. Now, let's move on to the second type of conjunctivitis that we should study. This conjunctivitis that you see the photograph on the right side is known as Apollo conjunctivitis, or more popularly known as acute hemorrhagic conjunctivitis. Okay. Now, as you will be able to see in the photograph, both the palpebral conjunctiva and the bulbar conjunctiva in both the eyes have absolute complete hemorrhages. Okay, everybody? Now, easy photograph to diagnose. The important question that is asked here, apart from the image, is what are the causes? So, number 1, everybody. The most common cause is picornavirus. Now, picornavirus family can be divided into 2 further causes. So I'm saying number 2, which is a type of picornavirus, enterovirus type 70, Coxsackie A24. Okay. So even though I've listed them as number 1, number 2, number 3, but please remember your microbiology, picornavirus, subtype enterovirus, subtype Coxsackie virus. Okay, everybody? Please remember these numbers. These are important. That is what is asked. So in 2017 examination, everybody, they had asked a simple question. Which type of enterovirus causes acute hemorrhagic conjunctivitis? So you had to remember type 70 also. Now, the fourth cause is adenovirus type 11. So these are the 4 causes. These are the 4 names which you need to learn. This kind of a question has been asked zillion number of times, everybody. Please do remember them. To remember them, PACE. This is what you can use. Picornavirus, adenovirus, and then 2 types of picornavirus, that is Coxsackie and enterovirus, PACE. Okay, everybody? There can be various other mnemonics which you can form. Your wish, which way you remember. Now, another important type of viral conjunctivitis is this. Without writing the name, if I show you this photograph, this everybody, can you identify what kind of lesion is it? I hope yes. See everybody, this is a nodule which is umbilicated. Can I call it an umbilicated nodule? Yes, guys. A nodule with a dip in the center. Dip in the center. Umbilicated nodule is reminiscent of molluscum contagiosum. Yes, everybody. So this is a mollusk lesion. Now, what occurs from this nodule? This nodule carries virus particles. So these virus particles are shed from time to time, and these lead to mild conjunctivitis. Am I clear? Apart from this nodule is absolutely harmless. You don't need to remove it unless it is cosmetically a blemish to the patient. Am I absolutely clear about this? That's all about the very simple condition that is viral conjunctivitis. Chlamydial conjunctivitis. As we already know, again I'll go back to the table that we have drawn. Chlamydia will present with follicles along with mucopurulent discharge. Yes? So that is what we have written, follicles plus mucopurulent discharge in all cases. Now chlamydial conjunctivitis can present in 3 diseases. Number 1, adult inclusion conjunctivitis. Number 2, the important disease trachoma. And number 3, ophthalmia neonatorum. Neonatorum, again telling you that the condition is occurring in neonates. Please remember, adult inclusion conjunctivitis as written is caused in D2K serovar of Chlamydia trachomatis. Trachoma by A, B and C serovars. Ophthalmia neonatorum, if caused by chlamydia, is by D2K, but there are other causes also. There is nothing much to discuss in adult inclusion conjunctivitis. We only need to know the serovars, that it has follicles and mucopurulent discharge, everything written here. What we need to discuss in detail is the epidemic or the pandemic trachoma, everybody, which is also covered under the Vision 2020 program, if you know. Yes? And we will discuss ophthalmia neonatorum and its various causes. Am I clear, everybody? Now, let's start with the first disease that we said, trachoma. Trachoma is also known as Egyptian ophthalmia. It's a very old name. Please do remember it. Sometimes it is mentioned in the question. As we already know, just writing again, it is caused by chlamydia trachomatis A, B, B subtype A and C serovars. That is the first thing that we need to remember. Secondly, everybody, what are the modes of transmission? Whether you have read PSM, whether you have read microbiology, I don't know. But this is taught in all those subjects also by the simple fundamental of FFF. Okay? Finger, fly or fomite. Am I clear? So basically this is getting transmitted. It is contiguous. You have the discharge. Yes, you are rubbing your eyes. Your hands are dirty, your fingers are dirty, then those fingers are being touched by somebody else. So there is contiguous, there is transmission. Similarly, the fly will come and sit on your face on the discharge mucopurulent and then will transfer. And fomite means objects such as handkerchiefs. Am I clear, everybody? So finger, fly, fomite. No confusion should be there, everybody. This is most commonly seen in children less than 10 years of age. Done? So basic epidemiologic characteristics. Now, how does it present? Clinical features, everybody. So for clinical features, what you need to remember is 2 things. Number 1, this is a type 4 hypersensitivity reaction. And very importantly, active inflammation plus cicatrization are present together. This is very important. Usually in diseases, what do we say? That first of all, inflammation will occur. After that, the second stage of healing will occur. Yes? Here we say inflammation is continuing, but the healing will start to occur along with it. So you will be able to see signs, both of them together. As a sign of active inflammation, everybody, what will you be able to see? Papilla or follicles? We already know follicles. Those follicles are specifically called as sago grain follicles. Sago grain, I hope you have heard the name. It's a smaller grain than rice, everybody. So almost like dana. So you will be able to see a lot of follicles here, white colored, everybody, but which are very, very, very small, everybody. So like sago grains. They are most commonly seen in upper palpebral conjunctiva. As you can see in the photograph also, the upper conjunctiva has been shown by eversion of the upper eyelid. Yes? Characteristically, these follicles show necrosis. The follicles get necrosed, and if you do the histology, you will find Leber cells present within these follicles. These are the two distinguishing features of follicles caused by trachoma versus the follicles, let's say, in viral conjunctivitis. Am I absolutely crystal clear here? No? Right? Now, let's move on to the second sign. These are now the cicatricial signs, everybody. Follicles were occurring in the active stage, but along with that, healing has started to occur. So you see a line of cicatrization, and this line is known as Art's line. Art's line. I'm writing, everybody, what is Art's line? Line of cicatrization or healing, everybody, which is present between the lower 2/3 and upper 1/3. Okay, everybody? You can see the arrow, everybody, here, which I have colored with blue now. You can see a faint line, white line of fibrosis or cicatrization. If you are wondering why I have written lower at the upper side and upper at the lower side, please understand that the eyelid has been everted. Eyelid ulta ho gaya hai. So the lower part is visible upper and the upper part is visible lower. Okay? So usually the location of the line is upper 1/3 and lower 2/3 junction. Am I clear to everybody? No confusion should be there? Now, the third feature, everybody, again a feature of the cicatricial stage, is called as Herbert-Pitts. This is pathognomic for trachoma, and this is due to healing of limbal follicles. Everybody, even though we said the follicles will usually be present in the upper tarsal conjunctiva, but they can also be present at the ending of the bulbar conjunctiva, that is at the limbus, everybody. So at the limbus, the follicles which were there, if they heal, they will leave small depressions, everybody. Gaddhe or pits, everybody. Yes? So let's see this photograph, a highly zoomed photograph. This white area is your sclera. I hope you understand this. This central black area which is appearing transparent is cornea, everybody. Then what is this, everybody? This is your limbus. At the limbus, if I draw the outline, everybody, you will be able to see pits. Pit number 1, 2, 3, 4, 5. So all these follicles were there which have healed now and have left small depressions. This is pathognomic for trachoma. Am I crystal clear? Now, the last important sign, everybody, is known as pannus, as you can see written below the photograph also. If you know what is pannus, good enough. Otherwise, it is being clearly visible in the photograph. What is pannus for everybody? Vascularization of cornea from the superior side. Am I clear to everybody? Cornea is avascular, but if it becomes vascular, the lymphoid aggregates are there at the limbus and the vascularization is occurring in the cornea. Done, everybody? No confusion about this? Pannus. Now, these are the important 4 signs, everybody. Please remember them. I've shown you all the 4 photographs also. Very important condition, trachoma, because it is still prevalent in India. Am I clear? No confusion? Now, apart from this, please remember that the only complication is a corneal ulcer, which occurs due to trichiasis. If you know what is trichiasis, or if you have seen the lecture on eyelids, everybody, trichiasis is inward growth of the eyelashes. So again, if I draw a simple cut section, cornea, sclera, this is my upper eyelid, this is my lower eyelid. Yes? Normally my eyelashes grow out. But if the eyelashes have started to grow in, everybody, they are rubbing on the cornea. When they keep on rubbing onto the cornea, there will be irritation and it may lead to corneal ulcer. Am I clear to everybody? This corneal ulcer heals to form a scar, and this scar will lead to loss of vision. Do you understand why trachoma is important? It is conjunctivitis. So ideally, conjunctiva is not covering the cornea, so there is no interference with vision. But because of this complication, everybody, because of the associated trichiasis, we know that trachoma may lead to loss of vision, may lead to blindness, everybody. And that is why it is a condition which has been taken into all the programs, everybody, which we are trying to treat, everybody. Am I absolutely clear about this? No confusion? Done? Now, what is the treatment? If it is such an important condition, what is the treatment? Again, you should have read it in PSM, the name SAFE strategy. If not, everybody, then let's see the treatment here, everybody. SAFE strategy. SAFE strategy was advocated by WHO in the year 1996. SAFE. 4 things need to be done, everybody. As you can see in this photograph here. S for surgery. Surgery for what, everybody? Inturned eyelids or trichiasis. As we just now noted, trichiasis will lead to ulcer and opacity and then ultimately loss of vision. So if the eyelashes are turned in, you need to remove, then you need to do cryosurgery. Then A for antibiotics. It is an infection at last, so you need to give antibiotics. What is the drug of choice? The drug of choice is azithromycin 1 gram. Then F for facial cleanliness, because it can be transmitted by FFF to stop the transmission. And then E for environmental hygiene, everybody, to increase the access to water and sanitation, to be able to clean the eyes, to have proper environment so that flies don't form in the neighborhood. Am I clear to everybody? SAFE. Now, how is the treatment indicated? So everybody, if prevalence is greater than 10% in children aged 1 to 9 years, then we say mass prophylaxis needs to be given. Okay, everybody? Secondly, if between 5 to 10% prevalence, everybody, then we say treat affected children and families. Then you don't need to do a mass prophylaxis, everybody. And lastly, if it is less than 5%, then only F and E should be able to take care. That is facial cleanliness and environmental hygiene. Done, everybody? There should be no confusion about this. I hope I am absolutely clear about the treatment and how it is instituted. Done? Now, lastly, to finish the topic of trachoma, everybody, we should know the classification of trachoma, which has been given by WHO, which is popularly called as FISTO classification. FISTO. 5 stages, everybody. Let's see the first stage. TF, trachomatous follicular inflammation. Okay, everybody. First of all, what will form? Follicles. This is in the active stage. So greater than 5 follicles should be there. 5 or more follicles, everybody. Okay. Second stage, what is occurring, everybody? The inflammation is becoming more intense. TI, everybody. Follicle intense. If it is intense, along with the follicles, there is thickening of the upper palpebral conjunctiva. Then, if it proceeds, what will start to occur, everybody? Scarring. Art's line, everybody. Scarring in the conjunctiva, everybody. Yes or no? Scarring in the conjunctiva. Am I clear to everybody? This we say now is the inactive stage. The first 2 stages were active. I hope you understand. Follicles were forming in the first stage. Then the inflammation was getting intense. Active stages. So in both the stages, we need to do treatment by antibiotic. Here we don't need any treatment because it is inactive stage. Then everybody, in the 4th stage, if it progresses, there will be trichiasis. So we already know for trichiasis what we need to do. Surgery. And lastly, if you don't do anything, opacity will form. O for opacity. So there will be visual impairment due to the corneal opacity, as already explained. So very easy to remember. FISTO, follicle intense inflammation. Then S for scarring. Then T for trichiasis. And lastly O for opacity. Done, everybody? No confusion about this? That's all about the important topic, trachoma. If you ask me, sir, what is the single most condition in conjunctiva, I will say trachoma. Please do remember every simple point that we have shown you and told you, and all the 4 or 5 photographs. Now, as noted, everybody, the next topic in relation to chlamydial conjunctivitis that we want to study is ophthalmia neonatorum. As is clear from the image, everybody, we are saying conjunctivitis in a neonate. That means less than 28 days age of onset. Okay, everybody? You don't want infection to occur in a newborn or neonate. That is why this becomes an important condition to prevent basically, or if it has occurred, to treat promptly. Am I clear? Ophthalmia neonatorum. But apart from chlamydia, there are various other causes depending on the time of onset. Okay, so that's what we are trying to see here, causes and time of onset of ophthalmia neonatorum. So we are making a table here, everybody. Number 1, if the onset is within 6 hours of birth, then we say it is chemical conjunctivitis. Chemical conjunctivitis due to application of silver nitrate solution. We'll get back to it. Secondly, everybody, if the onset is within 1 to 2 days, or I am writing 24 to 48 hours, then we have a very important cause, a severe cause, Neisseria gonorrhoeae. This is the most severe form of ophthalmia neonatorum. Thirdly, everybody, if the onset is after 2 days, 2 to 5 days, everybody. Am I clear, everybody? Then the cause is other bacteria. When we say other bacteria, we are basically excluding Neisseria, that's all. If the onset is 5 to 7 days, then the cause is, everybody, herpes simplex virus type 2. And lastly, if greater than 1 week, then we have what we were discussing here, chlamydia trachomatis. And if you saw the classification, D to K serovars. Please remember that this is the most common cause of ophthalmia neonatorum, and that's why we have discussed it under the chlamydial conjunctivitis topic here. Okay, everybody? Please do remember this table, everybody. Simple questions are asked, nothing difficult is here. Just remember the time and the cause along with it. Okay, everybody? Done? Now, how to prevent this? If this can occur, there are so many causes, then our aim is to be able to prevent this. So prevention in the yesteryears, everybody, was done by something called as Creed's method. What did the Creed's method say? Creed's method said, everybody, that there should be application of topical 1% silver nitrate. Now do you understand? This was the method of prevention. But it was noted that in a lot of cases, the silver nitrate itself was causing conjunctivitis within the first 6 hours. So this is not recommended nowadays. Okay? Nowadays, instead what is recommended, everybody, is either a 0.5% erythromycin or a 1% tetracycline, everybody, single application within 1 hour of birth. Okay? Am I clear, everybody? No confusion should be there on this. Simple fundamental. Creed's method, please remember, it was a prevention, but it used to cause chemical conjunctivitis. So now we have shifted to number 2 or number 3. That's all about ophthalmia neonatorum. Very simple. That's all about the 2 conditions we were discussing in chlamydial conjunctivitis, that is trachoma and ophthalmia neonatorum, both important conditions as far as MCQs and the effect of it on the population is concerned. Now we start with the last group of conjunctivitis that we are left with, everybody. So now, last type is allergic conjunctivitis, right? Allergic conjunctivitis, again, as we have already seen, guys, allergic conjunctivitis will present with a watery discharge with papilla. That has what has been written on the screen, papilla with watery discharge, and the characteristic symptom only associated with allergic conditions, that is itching. Okay? So all the 3 words are written here. Now, just like all the other types of conjunctivitis that we have studied, there are various ways in which allergic conjunctivitis can present. The first type we will be discussing here is a very important condition known as vernal keratoconjunctivitis, which is also popularly known as spring catarrh. Please note, it is not a venereal disease. We have not written venereal keratoconjunctivitis. It's a very small difference, but please remember it's not an STD, everybody. It's vernal keratoconjunctivitis. This occurs in children having type 1 hypersensitivity reaction to allergens such as pollen. Okay? I said children. Children means either boys or girls. So it is more common in boys. So I'm writing the age 5 to 15 years of age. This is more common in spring and summers. If you understand the weathers, everybody, India is blessed with these 4 weathers. Spring, summer, autumn, winter, even though spring is just probably 10 days and autumn is probably just 10 days. Spring, summer means, spring means after winter, that March kind of, yes, when you don't need a fan and you don't need a sweater also. Okay, everybody? So that's spring, and then the whole long summer in India, everybody. So spring and summer, this is the kind of season that you will have children presenting with allergic symptoms, everybody. Am I clear? No confusion about this? Now, everybody, you will usually find history of atopy also present. They may have other atopic diseases, atopic conditions present along with. Done? Now, let's move on to the clinical features. So, clinical features, everybody, we know that the main clinical feature will be a papilla. Yes? So, I'm writing papilla or papillary hypertrophy, which presents as a specific appearance famously known as cobblestone papilla. Why cobblestone, guys? If you have ever walked on a footpath, everybody, on footpath you will see that there is such a kind of a pattern of all the bricks that are laid, everybody. Yes? If you look at the papilla, it looks the same, everybody. Yes? That somebody has laid the bricks on a footpath, everybody. And there are little gaps between all those bricks. That is why it gets the name cobblestone papilla, right? These are usually giant papilla, greater than 1 mm in size. Greater than 1 mm in size. Am I clear? Now, secondly, everybody, the second important diagnostic sign is known as Horner-Trantas dots. Horner-Trantas dots. These are collections of eosinophils, allergy eosinophils, I hope you can correlate, and epithelial debris. Okay, but where? That's the important diagnostic point. On limbus. Why am I saying it is important, everybody? We just now saw in trachoma also on limbus an important sign is seen, that is Herbert Pitts. If you focus on the name Pitts, Pitts meant depression. So if you see a depression at the limbus, it is more likely to be trachoma. But this is a spot, this is a deposit. So a raised deposit is more likely to be VKC. Both the signs are seen at limbus. So 2 differential diagnoses of a sign at limbus. Am I absolutely clear? Let's see the photograph, everybody. I hope you can see at the limbus 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So many deposits, everybody. Am I absolutely clear? So this is Horner-Trantas dots. Done? Then the third sign is pseudogerontoxon. Pseudogerontoxon. Paralimbal, around the limbus, a gray white band of lipid deposition. Paralimbal gray white band of lipid deposition. Okay, first of all, let's see it in the same photograph. Can you see at the margin of the cornea, everybody, this? I hope you can. Paralimbal gray white band. Yes, done, everybody. This is your pseudogerontoxon. But why is it being called as pseudogerontoxon? If you focus on the nomenclature, gerontoxon, geriatric population, old age, we are trying to say that this paralimbal band looks something like which occurs in old age. In old age, something is seen which is called as arcus senilis. Cornea, everybody. What is arcus senilis? In old age, paralimbal gray white deposition, everybody, of lipid. Yes. So this is giving the same appearance of arcus senilis. So something which is seen in the old population, but this is being seen in children. Pseudogerontoxin. Am I absolutely clear? Then the fourth important clinical feature that you need to remember is something called as shield ulcer. Obviously, it's a corneal ulcer which is given the name shield ulcer. Number 5, everybody, there is a sign which is called as Denny-Morgan line. This is an extra lower lid crease. Not a very important, not a very diagnostic sign, just know it. Number 6, everybody, Maxwell-Lyon sign. It's a very good sign if you watch cricket, guys. Name of 2 cricketers in Australia, Glenn Maxwell and Nathan Lyon, everybody. Yes. So Maxwell-Lyon sign. What is this, everybody? There is a ropey discharge. What do I mean to say by a ropey discharge? This is almost a characteristic feature. We have said that in allergic conditions, there is no mucus, there is no pus. The discharge is watery. But in case specifically of VKC, whenever you will try to rub the eye to remove the watery deposit, you will say kind of sticky rope is formed. So even though it is water, a little bit of mucus is present. So it forms ropes, everybody, kind of strings, everybody. That's why it gets to be known as ropey discharge. Please remember this, important. Done, everybody? These are all the important signs. Also remember, due to excessive itching, which leads to rubbing of eyes, children who are untreated, they will constantly be rubbing their eyes. This leads to greater incidence of keratoconus, cone-shaped cornea. Try to imagine something which is convex. You are rubbing it. So you have this kind of a force. You understand what kind of a force? A cone-shaped force. So I am rubbing my eyes like this, everybody. A cone kind of a force. So both the eyes assume a conical shape. Yes? Greater incidence of keratoconus. Done? Lastly, everybody, what we need to know is the treatment of VKC should be a no-brainer, everybody. It's an allergic condition. If it's an allergic condition, the first thing I can give is cool compresses, home treatment. Secondly, I can give topical antihistamines like cetirizine. Thirdly, we can give topical mast cell stabilizers like sodium chromoglycate or lodoxamide. But the drug of choice, if I say a compound is olopatadine, or I can say alcaftadine. Okay, everybody? What are these, everybody? These are 2 plus 3. Can I say, everybody? Antihistamines plus mast cell stabilizers. Done? No confusion? Point number 5. Along with the anti-allergic treatment, it is almost always that you will see that topical steroids are also being prescribed as part of acute exacerbations. Okay? And then they will be tapered down. Anti-allergic medications topically, they take a while to reach their effect, everybody. So topical steroids are added in acute exacerbations to reduce the symptoms. They are tapered down, and by that time the anti-allergic phenomena will be in effect. Am I clear to everybody? So please do remember, steroids are used in certain conditions. It's not that steroids are always contraindicated, just like in corneal ulcer they are used at some places. Similarly, in conjunctivitis also they are used in certain conditions. That's it about my important condition, allergic condition, that is VKC, vernal keratoconjunctivitis. If you ask me, sir, what is the second most important condition in conjunctivitis after trachoma, I will say VKC or vernal keratoconjunctivitis. But apart from VKC, there are other allergic conditions also that we need to study. So the second allergic condition that we will be studying is known as atopic keratoconjunctivitis. As opposed to VKC, this occurs in old age, 2nd to 5th decade. Okay, everybody? Then this also involves the eyelids. Eyelids show something called as the Hartog sign. The lateral eyebrow are lost. Hartog sign. Apart from that, it is similar that there will be papilla, everybody, there will be watery discharge, the patient will complain of itching. The treatment will also be the same in the form of antihistamines and topical mast cell stabilizers, right? So just two important points which differentiate it from VKC in terms of age and a specific presentation. Now, let's move on to the third type of allergic condition that we want to study, giant papillary conjunctivitis. In this case, you will see giant papilla being formed. First of all, giant papilla is greater than 1 mm in diameter. We know this. Secondly, know that this is a type 4 hypersensitivity reaction. Thirdly, GPC or giant papillary conjunctivitis is mechanically induced by, you will understand it yourself, number 1, contact lenses. If you've ever worn a contact lens, you will understand it yourself. If you don't know how to correctly wear a contact lens, or if by mistake one of the edges of the contact lens remains slightly raised, whenever you will blink, you will feel irritation, yes. But what is occurring? The contact lens edge is rubbing with the inner margin of the palpebral conjunctiva every time you blink. So when there is rubbing, everybody, what is occurring, everybody? Mechanically induced inflammation, giant papillary conjunctivitis. Similarly, if somebody has lost his or her eye and is wearing an ocular prosthesis, artificial eye, everybody, then also artificial eye needs to be put in correctly. If not, then the margin of the prosthetic eye can rub against the eyelid. Okay? Or thirdly, if there are any protruding sutures. Protruding sutures. Am I clear, everybody? After any surgery or anything, if we have applied sutures, everybody, if we have not buried the end of the suture and it is pointing out like this, it will again rub against my eyelid margin. There should be no confusion about this. The treatment is the same, everybody, that you need to remove the cause in this case basically, and then obviously give antihistamines to bring down the allergy. Now, after this, the next type of allergic conjunctivitis that we want to study is flectennular conjunctivitis. First of all, please know that this is a type 4 hypersensitivity reaction mediated in response to endogenous allergens. I hope you understand why I am emphasizing on the word endogenous. When we talked about VKC, we said it is mediated by pollen and other those factors. When we said giant papillary conjunctivitis, again an external factor like a contact lens or a protruding suture. But in flectennular conjunctivitis, there is some kind of disease inside the body, endogenous allergens. Yes? So what is the cause, everybody? The cause is either tuberculosis or Staphylococcus aureus. Okay? Hypersensitivity to the proteins produced by Staphylococcus or tuberculosis. Am I crystal clear? In countries like India where tuberculosis is still prevalent, tuberculosis is the more common cause. But in the Western countries where tuberculosis is now no more present, Staphylococcus aureus is the more common cause. Right? Now, if I focus on the name, flecten, this is the word, flecten. What is a clinical feature, everybody? This is the clinical feature. Clinical feature is a flecten. What is a flecten? It's a nodule. Can you see the nodule here, everybody? Yes? So it's a nodule near the limbus. Flecten. That's why it is called flectennular conjunctivitis. This flecten grows towards the cornea. Okay, everybody? So it goes from the periphery onto the cornea. So it will grow here, everybody. When it will grow here, it will ulcerate. And when it ulcerates, it gives rise to 3 types of ulcer, everybody. What are the 3 types of ulcer? Number 1, sacrophilus ulcer. Number 2, fascicular ulcer. And number 3, miliary ulcer. Just remember these 3 names, that phylactenular keratoconjunctivitis is presenting with keratic, that means corneal signs, which have been listed for you. 3 names, sacrophilus, miliary and fascicular. Done, everybody? No confusion should be there. The treatment is steroids. Topical steroids are the preferred treatment instead of anti-allergics here. Just remember this because this is an endogenous allergy. That's all about our major important types of allergic conjunctivitis. That's all about our topic conjunctivitis. Everybody, we have started conjunctivitis with the discussion of all the important signs. Everybody, I have shown you photographs of chemosis, papilla, follicle. Please remember the 2x2 table, everybody. What if follicles and watery discharge? What if papilla and mucopollulant discharge? That is the most important. Then the 4 groups, everybody. Bacterial, 5 types. Viral, 2 important types, everybody. The important type is acute hemorrhagic. Then chlamydial, trachoma and ophthalmia and neonatal. And lastly, allergic. The most important condition being VKC. We have studied 4 simple conditions in this. These are all the forms of conjunctivitis. Very easy, nothing much to understand. Again, just remember it and answer this. If you are wise, you will be able to remember 50% of it very easily by papilla, discharge and the main symptom, and then some specific presentations at some specific places. Now, apart from conjunctivitis, everybody, the main important pathology that we want to study in conjunctiva is our favorite pathology that somehow we keep on studying throughout the year of our 3rd year, everybody. Everybody asks it, pterygium, everybody. Yes, so let's move on to our last topic in conjunctiva that we want to study, and that is pterygium. As soon as I show you this photograph of pterygium, I hope you can recognize it at least. So what is pterygium, everybody? A triangular growth of the degenerated conjunctiva over the cornea. Am I clear to everybody? This is what the image looks like. Any image like this, a triangular growth of conjunctiva over cornea, is a pterygium. Now let's define pterygium. So the definition goes like triangular, first of all, fibrovascular growth of degenerative subconjunctival tissue over the cornea. See, again and again I am saying this is the most important thing. Conjunctiva growing over the cornea, destroying Bowman's and superficial stroma. Okay, everybody? These are the 2 things that it is destroying. Now, we should know that it is associated with ultraviolet rays exposure, UV rays exposure. It is associated with dust, humidity, etc. Okay. Then, as another important knowledge that we have acquired about it, it is now known that pterygium is also due to limbal stem cell deficiency. Limbal stem cell deficiency is leading to activation of matrix metalloproteinases, which is leading to this degenerative condition. So please remember this line, limbal stem cell deficiency. Am I crystal clear about this? Yes, sir? Now, once we know this basic fundamental of how it occurs, what are the clinical features? Number 1, everybody, please remember it is a triangular growth with the apex towards cornea, always apex towards cornea. Number 2, everybody, there is something called as Stocker's line. What is Stocker's line, everybody? Deposition of, see, all of you know this. We are just kind of revising here, yes or no? Deposition of iron in front of apex of pterygium. So right at the tip of the pterygium, you will see a brown colored faint deposition, iron deposition. Thirdly, everybody, this presents with loss of vision. Why does it cause loss of vision? That's the case now. A, the fibrous tissue will exert some kind of change in curvature by the pull, everybody, which will lead to corneal astigmatism. Okay, astigmatism can lead to loss of vision, visual disturbance. Secondly, it can encroach over visual axis if it is covering the pupillary area. What do I mean to say about it? Let's understand, everybody, these 2 points. It will induce corneal astigmatism or it will encroach over the visual axis. I will show you 2 photographs, everybody. Photograph number 1 and photograph number 2. Can you tell me what will be the cause of loss of vision in photograph number 1? Whether it will be astigmatism or encroaching over the visual axis. See, simple English. We are saying that the pterygium is now growing and it is covering the pupillary area. When it is covering the pupillary area, basically it is not allowing light to get inside the pupil. Yes? So I am saying it is coming between the visual axis. Encroaching visual axis. Do you understand, everybody? But in the second image, everybody, if I see carefully, my pterygium, even though it is covering the cornea, it has not come in front of the pupil as yet. See, the light has to go from the center of the pupil. So all the light rays will be able to go and form an image on the retina. So that means in such a case, the cause of visual disturbances will be corneal astigmatism. Am I clear? This question was asked in NEET 2019, everybody. This was the only common sense that we needed to apply. Students who were able to do that found it easy. That's all, everybody. Theory, everybody knows. But we need to apply that theory common sense into an image also. I hope I'm crystal clear by these 2 images here. Yes? Now, let's move back. Once we've been able to diagnose pterygium, which is very easy, what we need to do, everybody, is the treatment of pterygium. So what is the treatment of pterygium? Is there any drug which can dissolve the pterygium? No, everybody. The only treatment is surgical excision. Okay? You have to cut, you have to scrape over the cornea, you have to remove it. But if you only do surgical excision, there is a high rate of recurrence. To reduce the recurrence, what you have to do along with that is, you have to apply topical mitomycin C, antimetabolite, so that it does not grow again. Or what you have to do is, you have to do autografting. Okay? So usually, if you have seen the photograph, I will again show you the photograph. Usually it grows where, everybody? Nasally. Pterygium usually grows nasally. So nasal part of the conjunctiva has now been cut, surgically resected. We choose an area inferiorly or superiorly, everybody. We cut that part of conjunctiva and we graft it over the nasal part. We are basically giving it back the limbal stem cells. Do you understand this, everybody? Yes. So graft harvested from the same eye. Graft is harvested from the same eye, usually superiorly. Okay? Then it is sutures are used to fix it, or fibrin glue is used to fix it, or we say autologous serum, or we say autologous serum. Okay? So you will apply some kind of a suture, or you will apply some kind of a glue, everybody, or you just leave it. All the blood vessels that are oozing serum, they will lead to suction, and this will also be able to graft out. Done, everybody? This is how you prevent the recurrence. Autografting is usually done, and mitomycin C is usually applied to reduce the recurrence, as already told to you. To end the chapter, everybody, let's just do two simple conjunctival degenerations, which are just like pterygium, degenerative conditions of the conjunctiva. One thing which usually I've seen students confuse with pterygium is this, everybody. This is known as pingecula. Yes? What is pingecula? First of all, let's see the theory. Pingecula is elastotic degeneration of collagen fibers in stroma of conjunctiva. Okay? It is nothing like pterygium. There is no growth of the conjunctival tissue over the cornea. It just looks like that because it is also kind of triangular, even though I will say it's a reverse triangle. But if we look closely at it, everybody, we will see that it presents as fat-like nodule. Okay? It looks as fat-like nodules, yellowish in color. Am I clear to everybody? There is no fat deposition. It is elastotic degeneration, but that is the appearance it gives. It is more common on nasal part of conjunctiva, just like pterygium, and that is why beginners usually confuse pingecula a lot of times with pterygium. But if you try to carefully see it, there is absolutely no connection between the two degenerations. I hope this photograph makes it clear enough for all of you. Yes? Done? Now, the last degeneration, concretions. Another non-issue. It's an issue just because it causes irritation. See, what is there, everybody? Small elevations, everybody. Can you see? So, whenever the patient will blink, this will rub against the bulbar conjunctiva and the cornea, and that is why it will lead to what? Irritation. That is why the patient presents to you with such an inconsequential pathology. Yes? But what is it? It looks white deposition. So, a lot of times students think this is calcium deposition. There is no calcium deposition. Please remember. This is collection of epithelial debris and mucus. Okay? So this will appear like minute yellowish white elevations. You can just take a 26 gauge needle, prick them and remove everything. That's all. Or with time, if the lubrication is good, if the tear film quality is good, they will themselves get absorbed and disappear. Done, guys? That's all about my chapter on conjunctiva. I hope you have been able to understand that conjunctiva is nothing to waste time on. That conjunctiva as a chapter is purely a fact-based rote learning. There are lots of photographs, yes, photographs, but if you see once, you do not forget them. That's the ease of conjunctiva. Conjunctiva often gets asked as a single question in your All India or NEET exam. Apart from that, please, as I again say, find it easy, enjoy it, see it, learn it. Right, guys?